Genotype 4 is uncommon in the U.S., but is the predominant genotype in certain parts of the world, particularly in the Middle East. Egypt has very high rates of genotype 4. So in the U.S., we do have pockets of genotype 4 where we have immigrant populations. Genotype 4 has had limited treatment options because there haven't been enough patients enrolled in clinical trials for them to get approval for the regimens that are currently available. But it is likely that both the regimens that are currently approved for genotype 1 are effective in genotype 4, as well as regimens that are currently in evaluation and hopefully will be approved by the FDA soon. Whether we're going to see approval retrospectively for our current regimens, or whether it's going to have to be off-label use or some type of mixing and matching of drugs that have activity for genotype 4 remains to be determined. Genotype 4, like genotypes 2 and 3, was easier to treat in the interferon-based era than genotype 1, but has fallen behind because of lack of targeted drug development and, more importantly, of testing those drugs in adequate numbers of genotype 4 patients to get FDA approval. The group of people with genotype 4 have unfortunately high rates of cirrhosis because many of them acquired this decades ago during schistosomiasis vaccination in Egypt. And so genotype 4 with cirrhosis is a big group of patients. We don't have enough data to know how much they differ, but one ought to presume that, like genotypes 1, 2, and 3, genotype 4 with cirrhosis will be somewhat more resistant to cure than non-cirrhotic genotype 4. For patients with genotype 4 who fail prior therapy, once again, I think we're going to have to wait for pan-genotypic regimens where we can give, I think, at least 3 drug classes that are active in that genotype, with or without ribavirin, and duration, and we're just going to have to figure it out. But I suspect that if we choose agents that are active in genotype 1 and 4, that whatever works for 1 should work for 4. For patients who are genotype 5 and 6, they're so uncommon in the U.S. that there hasn't been an adequate number enrolled in any clinical trial to evaluate them. We see so few that I think most of the time we're going to have to be able to choose our information based on in vitro activity and then just try to design a regimen that works for them. I don't live in an area where I see adequate numbers of genotype 5 and 6. There are more on the West Coast, and hopefully we'll get some data from outside the U.S. that can guide our treatment decisions for those patients with genotype 5 and 6. One would suspect that for genotypes 5 and 6, the risk of cirrhosis once again has to do with duration of disease, and that I would suspect that the same thing about more difficult to treat, more likely to be a non-responder still is there, but our data is so limited for genotype 5 and 6, it's impossible to know that with certainty. I would suspect that if we design regimens for cirrhosis for the other genotypes, we'll apply those same rules, whether that's longer duration, the use of ribavirin, or additional drugs for the rarer genotypes.